a gastroenterologist at the University of Manitoba in Winnipeg, Canada, and my involvement with the ACG probably started when I was on faculty at UCLA just after my fellowship, so probably around the early 1990s. And I've been affiliated with the ACG ever since, and for the last 5 or 6 years I've been on the grant review committee for the ACG and have been invited here to speak at their American Journal of Gastroenterology lecture on the treatment of IBD. So the discussion today is going to be about treatment of IBD, and we focus treatment of IBD to date really on immune mechanisms, the response to whatever it is that causes IBD, and so in essence we're really putting a band-aid on what's going on in IBD because we don't know the specific cause, so we're trying to tampen down the immune response to whatever those causes may be. So a part of the discussion is going to be about the various treatments that are available, how to optimize their use, what's missing about those treatments. Part of it is the glass is half full when they actually work, and part of it is the glass being half empty when they really don't work, and to what extent they don't work. And a second aspect of treating IBD from a pathogenetic point of view, one aspect is the immune response, the other, which has become increasingly of interest and perhaps in the last decade, is impacting on the microbiome or a microbial response in treating IBD. And so we're going to touch upon that. There's much less data. There's really not well-founded treatments on impacting on the microbial aspect of the pathogenesis as opposed to the immune response. And then finally, I'm also going to be discussing simply treating patients' symptoms, because sometimes symptoms aren't actually generated or related to the active inflammatory component of the disease. One aspect that's of interest to our group is managing and dealing with and even just identifying when stress is an issue, because we've actually had undertaken some research showing that stress can really drive symptoms, even sometimes in the absence of active inflammation. Another important component is in relation to managing pain. Abdominal pain and joint pain are common complaints of patients with IBD, sometimes in patients who don't identify that their IBD is active. And while we can use some simple approaches to managing pain, like with acetaminophen analgesia, one trap that I warn the community about is starting on opiate analgesics and then ending with the spiraling course of continued ongoing and high-dose opiates, because we've actually have data from our center in a population-based way looking at all patients with IBD that high-dose opiate use is a predictor of mortality, actually. And the final comment is that in our same population-based database, we have presented data at a previous meeting, and just rounding these data up for publication, that at any one time about 50% of patients with IBD are actually on no IBD-specific therapy. Now, sometimes, in some instances, some of those patients really need to be on IBD-specific therapy and just aren't for a variety of reasons. Actually, the majority of them are in a long-standing remission and don't need to be in therapy. So there are a lot of patients out there that even though they have the diagnosis and have the label of IBD, they don't actually need specific therapies. So we're really in the early stages of defining, in fact, and I'm going to talk about the human microbiome in relation to the gut. There's skin microbiome, there's respiratory microbiome. You know, even though what we put in our mouth may actually impact what ends up in our gut, we know very little about the oral microbiome. But in terms of the gut microbiome, I still think we're a long ways from defining what even the normal microbiome is, and the very different types of people that exist in the world from different cultures who ingest different diets or of different ages and may have other diseases. And so similarly, I think we're still a long ways from defining what the real typical microbiome is in Crohn's disease versus ulcerative colitis, and in different phenotypes of Crohn's disease. So while people review topics and their research as if it's somewhat known what the microbiome is in Crohn's disease, I think there's still lots of work to define it. And so since it remains, I think, somewhat ill-defined, we don't have yet specific therapies to adequately harness it as a treatment. So our group has been very interested in psychosocial aspects of inflammatory bowel disease and the role that stress and actually, frankly, having diagnoses of depression or anxiety impact on disease course. And I think that, while lots of attention, and of course a lot of it is industry-driven, is directed towards pharmacotherapies that can be applied there. They're necessary. Certainly the advances of the last decade have changed the way we manage IBD. I think there's a whole other aspect of managing people with a chronic disease that's often overlooked. And I think that's a major area of focus for our group.